Hello and welcome to another episode of Rings a Bell podcast. If you're new here, my name is Kim Callio. I'm a registered pharmacist in beautiful British Columbia, Canada, but I haven't practiced actively since 2023 when I had my daughter. At that point, my clinical knowledge quickly began to fade into oblivion. Whether from lack of daily use or mom brain is contested. Either way, I needed to find a way to remain in the world of pharmacy and keep my knowledge up to date without dispensing. So I developed Rings a Bell podcast. In the show, I invite a guest on to quiz me on a topic of their choosing and then roast me on my less than optimal answers. The result is continuing education for busy pharmacy professionals that can be consumed anywhere, anytime. Today's episode is a special one as Rings a Bell podcast is officially 1 year old. We're into season 2, folks. In this episode, I welcome on Stacey D'Angelo, a pharmacist, certified health and well-being coach, and founder of Your Simple Health, a private practice focused on deprescribing and medication optimization. Stacey specializes in helping individuals safely reduce medication use when the risks may outweigh the benefits through personalized, evidence-based care and shared decision-making. Stacey is also a speaker and educator on deprescribing and has developed continuing education for pharmacists on patient-centered deprescribing strategies. Through her clinical practice and education work, she is passionate about changing the conversation around medications and helping both patients and healthcare professionals recognize when less medicine may be the right medicine. Before we launch into Stacey's episode, though, I have a note from my sponsors. Just kidding, I don't have any sponsors. And as it turns out, editing and hosting a podcast does cost money. My ask is this. If the podcast is providing you with genuine value, please consider supporting the show with a donation. I've set up an account with buymeacoffee.com, which will be linked in the description below. If everyone who listens to this show regularly were to donate $5, I'd be able to produce the show for a full year without spending my grocery money to do so. I totally understand if a cash donation isn't in the cards for you. There's other ways you can support the show. You could become a super fan, for example. Download all the podcast apps, follow on each one of them. Grab your grandma's phone and follow the show on her behalf. Follow on all the social channels, save or share posts. You get the point. Ugh, that felt kind of cringe. But I kind of had to ask because my accountant is begging me to recoup some of the expenses of this show. As usual, you'll find a link tree in the show notes where you can find references and useful tools and resources for each episode. That's also where you'll find links to become a guest, email me, follow on social, etc. Also, a gentle reminder for my listeners. This podcast is for informational and educational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or qualified healthcare provider with any questions you may have. If you are a medical professional listening to this show, please remember that clinical information moves swiftly these days. I do my best to present up-to-date information, but it is your responsibility to critically evaluate it before putting it into practice. Because you are a professional. Phew! With all that said, here is Season 2, Episode 1, Deprescribing with Stacey D'Angelo. Welcome, Stacey.
Thank you so much. Excited to be here.
Yeah, I've been really curious about deprescribing for a long time, but it seems to be something that, I don't know, it just hasn't lined up in my schedule to learn too much about. So this is going to be great. A little deep dive on deprescribing. How did you get into the world of deprescribing?
Yeah, great question. I feel like deprescribing is like, you're right, kind of like a hot topic, but also very important. And we actually do it every day as pharmacists. I think we're a lot of the time more focused on the on-ramp, like starting people on prescriptions and whatever kind of area that you practice, but it's just essentially the off-ramp. So whenever we're stopping medications, we're deprescribing. So I think people are doing it every day and thinking about deprescribing as this big elusive thing, but just putting more attention to the how and when and how we can be more conscious about deprescribing in our day-to-day practice. So it's a great topic. I'm glad you're focusing on it. In terms of my journey and how I became so focused on it, I would say like two things were very influential here. One is I started my career in long-term care as a clinical consultant. So I think this is where we kind of think about deprescribing a little bit more in that like geriatric polypharmacy setting. This is where the bulk of the research around deprescribing is as well. And I think anyone who out there who practices in long-term care will kind of resonate that like 90% of my recommendations to prescribers was to reduce a dose or stop a drug. So that was where I started kind of becoming more familiar and interested in it. And then later down my career kind of took a little bit of a twist, and I ended up opening a compounding pharmacy and integrative clinic. And there I did a lot of training around compounding, obviously, and I learned a lot more from patients about people who need to slowly taper off medications. And so I think that's another piece to deprescribing. I think we'll talk a little bit more about that today. But yeah, so like it doesn't have to be that geriatric polypharmacy situation. You can be on one medication and still need support around deprescribing. And so kind of got more interested in more learning around slow, safe tapers.
Gotcha. Yeah, I had a similar experience when I was working in a compounding pharmacy, which really shows you like, depending on the setting you're in, you'll have different people with different needs. Obviously, the base need in the population is the same, but you're going to get a different person coming in to see you, asking for capsules, empty capsules. And you're going, oh, what are we doing at home? And they say, oh, I'm taking my antidepressant and splitting it into little doses. That was my first sort of foray into what people were doing.
Yes, absolutely. And once you start going down the rabbit hole and learning what's happening out there in terms of, especially that kind of topic around, tapering slowly off of some of those medications that may be more difficult. There's so much information and so much feedback that I think we can learn from people out there.
Yeah, absolutely. Okay, well, let's see how I do. I'm ready for the quiz/roast.
Okay, we'll start with a kind of general, get the ball rolling here. Definition question. So what is deprescribing?
I'd say as opposed to just saying stop a drug, deprescribing is more of a systematic way of removing a medication without adversely affecting that person's stability or clinical picture.
Yes, very good. So deprescribing is the planned and supervised process of dose reduction or stopping of a medication that could be causing harm or just like no longer of benefit. So essentially like safely backing off or peeling off the gas pedal when it's appropriate to maximize a person's health and well-being. Okay.
All right. So the supervising being key there.
Yeah.
You're planning, but you're also monitoring.
Exactly. Okay. Doing it in conjunction with the healthcare provider. I think pharmacists, like the reason why I love talking about this specifically with pharmacists is because I feel like pharmacists are such a key health provider who could be participating in deprescribing and could be doing so much more of it. It's just so naturally ingrained in our training. And so I think that will come up a little bit more as we chat.
Absolutely. The monitoring plan for us has always been centered around actually checking in and calling as opposed to simply sending for lab results or something like that. Oh, hi. This is me attempting to fix an awkward transition after I had to pause the show to close my office window and I ruined the whole vibe. Anyway, back to the show now.
So what is a prescribing cascade?
A prescribing cascade is something I didn't hear about until maybe a couple of years ago. But now I'm hearing about it all the time. My understanding is you prescribe one medication, you end up with a side effect that then you prescribe a medication for, and then you get another side effect, and then you prescribe another medication for that. That's my understanding.
Yes, absolutely. Check. So I think you're right. I don't know when it came about in the literature, but the term prescribing cascade is relatively new. But it's essentially the awareness, the understanding that a medication side effect is mistaken for a new medical condition leading to another medication being prescribed to treat that adverse effect. So like an example could be someone's prescribed Effexor for, not supposed to use brand name. Okay, so an example could be someone's prescribed venlafaxine for depression. Subsequently, a few weeks later, they're getting insomnia or having difficulty sleeping. Especially in the context of depression, I think this could be a sign of depression. This could be part of what's happening with them, but it also is a side effect of the medication. And so that could be mistaken as a new symptom and prescribed something like Zopiclone, for example, which is just kind of piling on that additive risk for the patient rather than just addressing what caused it in the first place and potentially switching or reducing the dose or something like that.
Right. Switch to something other than venlafaxine, maybe something that gives you some sedation near bedtime as opposed to making you all hyped up.
Exactly.
Gotcha.
Okay, ready for the next question?
I mean, I'm not ready, but hit me.
All right, I'm going to move away from the definition type of question, and we'll give you a stats question and see how you do.
Stats. Okay? Famously, I'm really good at that.
Okay. So according to CIHI, the Canadian Institute for Health Information, approximately what proportion of Canadian seniors are prescribed 10 or more medication classes? Going to be multiple choice, okay?
Woof. 10
or more. Canadian seniors, so adults over 65. Is it 1 in 10, 1 in 5, 1 in 4, or 1 in 2? It's 10 or more.
1 in 5.
Very close. 1 in 4.
1 in 4?
Yeah,
Yikes.
1 in 4 Canadian seniors. This is from data out in 2021. So over 25%, actually 26.7% of Canadian seniors are prescribed 10 or more drug classes. And so they actually said classes. So like you got to think that accounts for like if they switch drug within class, so say they didn't tolerate a beta blocker and switched, that would still be included in that number.
And is this at one point they are on 10 classes at a time, or is that jeez Louise?
Yep. And actually that number is higher in women compared to men. So that's the total average out of all. Higher percentage in women, higher percentage in lower income categories, and obviously higher as we age. So in those 85 and older, 36% are on 10 or more medication classes.
Wow.
Yeah.
I mean, you know it in your gut when you see med profiles, but that percentage just kind of hits you.
Yeah. It's a lot.
Oy, oy, oy.
So that kind of brings us to the topic of like polypharmacy, that polypharmacy situation. So in the literature, polypharmacy is usually defined as like 5 or more regularly scheduled medications, which, by the way, if we look back at the CIHI data, I think it's a little bit older for this one, but like 2/3 of Canadian seniors are on 5 or more medications. So meet that category of polypharmacy.
Right. Okay. Yeah. I mean, it's not hard to get to 5.
No, it's quite easy. And that's why we see majority, 2/3 of seniors are on 5 medications.
Yeah, you could get there with 2 conditions.
And the thing is, polypharmacy is not always inappropriate. It can be appropriate. It can be beneficial. Obviously, there are conditions like diabetes, cardiovascular disease, which often go hand in hand, solid organ transplant, HIV, where like they're commonly appropriately prescribed this medication. But the important things is that people are on these medications and identifying inappropriate polypharmacy. So when is it too much? And are we reevaluating these people over time?
Yeah, just because it's appropriate prescribing doesn't make it any less clinically complicated too, right?
Yes.
You talk about the burden on pharmacists. You think you're checking 300 scripts a day. That's, could be very reasonable if they're all an 18-year-old on birth control.
Yeah.
But all of a sudden you're looking at, complex patients. It's a whole different day.
You're right. I mean, from a pharmacist perspective, to just make sure that that complex regimen is safe and effective. I think thinking back to the previous question around prescribing cascades, this is where I think pharmacists have a really great role to play as well, because not a lot of people are looking at a new symptom or condition. Could there be a drug-related cause? And this is something that's just so in our wheelhouse in terms of identifying those things.
Absolutely. Probably needs a little bit more of a systematic approach to looking at it, because generally that's not the first thing you're asking when you look at a script. You're asking, is this outright dangerous on its face? But, definitely something we could tackle more.
Absolutely. I'm glad you mentioned that, because we are going to get there.
Okay, cool.
But before we do, I'll ask you another question about polypharmacy. So which of the following has been associated with inappropriate polypharmacy? Is it A, increased risk of adverse drug events, B, reduced quality of life, C, increased hospitalizations, or D, all of the above?
All of the above.
Check. Yeah. And actually much more as well. Drug interactions, medication non-adherence, increased healthcare costs, and increased mortality. So straight up death, polypharmacy.
Straight up death.
Yeah. So yes, it can be appropriate in certain situations, but we know that it definitely is not always. And so it's like that reevaluation to see when we can pull back, when that is appropriate. Okay, I'll switch gears a little bit away from the kind of definitions and laying the foundations. And we'll talk more about the systems, as you mentioned. I think you led right into that so perfectly, Kim.
Love to give myself more quiz questions.
What is the first step when evaluating a patient for deprescribing? Is it A, identify the highest risk medication, B, develop a tapering schedule, C, obtain a complete medication history, including OTCs and supplements, or D, contact the prescriber?
I'm going C on this one.
C, absolutely. So the first step is always just doing a full assessment and obviously getting that best possible medication history, that full list. How many times as pharmacists have we talked to a patient where like there's things that are not on the profile or things that are on the profile that they're not taking, or something that they're taking that's samples or supplements or all of those things. So having a really good understanding of what they are taking, and then assessing the patient. So what symptoms are they experiencing? This is where you can identify those prescribing cascades. If there's any lab work available, understanding their diagnoses, understanding their full clinical picture, and then doing an assessment of each and every medication in terms of risk versus benefit for that patient over time. And that's going to lead you to identify any deprescribing opportunities. From there, like shared decision making is key, because just because you think something should be deprescribed or pulled back on or stopped doesn't mean that it aligns with the patient's goals and values. So this is something that's really prevalent or hit home in all of the deprescribing literature and guidelines and courses that are available out there, is that it really needs to be a joint discussion with the patient. It's not deprescribing isn't something we do to patients. It's something we do with patients. Right.
And I imagine you have a bit of an easier time because you actually run a specialized clinic. So patients are finding you and they know that they want to get off of something generally, or that's my assumption.
Yeah.
Whereas I could see, you're standing there in the pharmacy, you only have a couple of minutes with someone and you want to just throw this concept of getting off a med at them, might find yourself in more of a situation where they don't want it.
No, absolutely. And you know what? You can't force someone. You can't do it to them if they're not ready, especially if there is a potential, I'm sure we'll talk about this a little bit later, but if there is a potential of withdrawal symptoms, or it might not be that easy, there's a potential for challenge. you can't force this upon someone. You have to do it in conjunction with them. So that's a really good point. I will say there are some tools and resources to support pharmacists in having these discussions. There's a couple like handouts. There's one from JAMA that talks about just deprescribing generally. So if you saw a patient on 20 meds and you were like, okay, I would love to sit down and have a medication review with this person, and maybe they would do better if they pulled back on some things, like that talks generally about having a deprescribing focused conversation and how it can be helpful sometimes. And then there's handouts specifically around drug classes. So if you're like, oh, this person's on a sleeping pill and like they've been on it for so long, or they're on a really high dose, and like you want to broach that conversation carefully and not offend them or feel like you're trying to take away their medication, because that can come up. Just providing the information on risk and like saying, I'd love to have a conversation at some point when you're ready, or give book a time kind of thing.
I'm here, come to me when you're ready, not I'm here and I want to talk now.
Yeah. Yeah. And I want to take away your medications, because that's definitely can cause some fear. Yeah. So that's a little bit about process. I guess one more question around that. So which 4 components should be assessed with every medication during a deprescribing focused medication review? So four things. I'll give you a hint. There's an acronym, and we all learned it.
Oh, I'm not getting a multiple choice on this? You're
no multiple
asking
choice.
me.
Straight up.
Okay. Because I'm a terrible student. Can you repeat the question?
So which 4 components should be assessed for every medication during a deprescribing focused medication review?
Okay. Why are you taking it? Is it helping? Are you having any side effects with it? Have you ever tried to stop it?
Close. Yeah, very good. Or are you taking it?
Are you actually
or is there
taking
any
it?
barriers to taking it, right? Like in pharmacy school, I learned IESC. I don't know if you learned IESA. That's another common acronym.
You learned NESA, N-E-S-A?
Maybe.
Necessary, effective, safe, adherent.
Okay. Yes. Yes. So that's another acronym. I wasn't even familiar with that one, but yeah. Indication. Why are they taking it? Effectiveness. Is it working? Do they still need it? Is the indication still there? Safety. Is there any current side effects, or are they at higher risk of harm? Maybe that's another way to look at this question, especially in deprescribing, because they may have been started this medication 20 years ago, but you know, as they age, that risk benefit balance can change as well.
Right.
And adherence, or I learned C, which is cost and compliance. So are they taking it? Is there any barriers to taking it? Maybe they just hate taking it, you know, for whatever reason, but they still are. But they, on the flip side to that, oh, I don't want to stop my medication. Some people, oh, I have to take this medication. I hate it. And so their beliefs and values do come into play there, right? So.
Yeah. Well, and on the adherence, on the money side, it could have also been started 20 years ago when you were on a sweet corporate drug plan. And now you're on, you know, well, I was going to say Plan C in BC, but you're on the government plan and it's not covered. Now all of a sudden you have a fire under your butt to get off of the medication or switch to something else. Yeah.
And cost can be an issue overall and doing a deprescribing focused medication review, because maybe they're on many medications and cost is a barrier. They can't afford it and they're choosing. And so, of course, like, can you help them navigate the system to access other supports? But also, is there anything that's like that risk benefit ratio is not serving them as well as it once was?
Right. And if you're comfortable with me asking this, I understand that you run a private clinic where you help people with deprescribing. Do you find that patients are willing to pay because they know they're going to get off of things and have less consistent costs?
Yeah, for sure. I think that definitely comes into play. The patients I see kind of both buckets that we talked about earlier, both that like polypharmacy situation, usually by way of like an adult caregiver. So I usually see the 85-ish person who's like maybe living at home or cared by an adult usually daughter, who knows they're on multiple medications or multiple prescribers, and they just want an independent kind of third-party review to see if there's anything that, if everything is still appropriate, essentially. And after doing, I call it deprescribing focus, but really it's medication optimization. Sometimes they're having a symptom that's not being addressed. Sometimes we recommend to add some things too. But yeah, there's definitely motivation in terms of like wanting them to be on the right thing and having that confidence. And then I think on the other side of that patient population, where I see people who are, slowly coming off medications that need more support, that can cause withdrawal and those types of things. My practice is a bit unique because most of the time they've tried already and failed and need more support. And so it's not necessarily the motivation of being off this medication in 3 months and not having to pay for it anymore, but they just know they need more support. And so having that guidance is worthwhile.
Interesting. I can definitely, having worked a little bit adjacent to the long-term care, I can totally see the daughter of the 85-year-old saying, I don't want to ruffle the feathers of the doctor until I know everything I need to know, but I do want another opinion.
Yeah. And something I see a lot is there's multiple prescribers involved who don't want to step on each other's toes.
Right.
And, that's one question I get asked a lot, and starting to work with people is like, oh, what's the doctor's response to you coming in with this medication review? And to be honest, that is definitely a possibility. And I always am honest about that of course you can have someone with an ego who doesn't want to take your recommendation or whatever. But so far, knock on wood, I have 100% success rate. And I think that's because it's always about decreasing risk. So it's helping to reduce liability on all fronts as well. And, for people who are coming to me who are willing to spend the time and the money to do this, and we come up with a plan together, they're also on board. So again, you're not doing something to them. This is something that the patient wants, and it's decreasing risk and decreasing liability. So I think that helps as well when you come at it from that angle.
Yeah. And I imagine you're simplifying things for multiple people at the same time, as opposed to, we always get the pushback on, is this an appropriate drug? What are you doing? Why are you giving this? And the doctor's like, I just saw the patient. Now I got to call them back. I got to get something else. I got to call you back, blah, blah, blah. And it's just a never ending discussion. Whereas if you're doing it all at once, you've made their life easier.
Yeah. Exactly.
Cool. You're doing the Lord's work.
Oh, thank you so much. I love it. It's very rewarding. Okay. You ready for your next question? I have a case-based question for you, but it is multiple choice. So a 90-year-old woman with advanced frailty asks whether she still needs her statin. According to the new Canadian deprescribing guideline, which one factor alone should determine whether deprescribing is appropriate? Is it A, age, B, LDL cholesterol, C, duration of statin therapy, or D, none of the above?
Ooh, hit me with the none of the above. I sense that this is a trap, but I'm still going to go A, age.
Okay, your sense was right. Always go with your gut, Kim.
I know. I knew it was a trap, but I didn't know how to assess it or move on. So I just was like, finish the question. Yeah.
So yes, the answer is none of the above. So this was a slight trick question. So gotta give you that. I wanted to put this in because the new guidelines did come out around deprescribing of statins, and basically they emphasize that there's not a single factor that determines whether deprescribing is appropriate. The only thing they might I would say is life. They did specifically say life expectancy. So if the person is at end of life, then suggest discontinuing. There's no difference in the research in chance of death at 60 days of a cardiovascular event or, death at 60 days or cardiovascular events at 1 year. So at end of life, suggest discontinuing. But prior to that, It's basically like have a conversation. And even at end of life, it says have a conversation with the patient and see what their values are.
Right. If that person feels more comfortable with a statin, it's probably not the biggest deal.
Yeah, it's not harming them. But basically they said essentially anyone else before end of life, decisions should integrate how frail they are, life expectancy, primary versus secondary prevention, time to benefit, adverse effects, patient's goals and preferences.
Okay.
So like having a conversation. But I know this comes up for me a lot, I'm sure, with many pharmacists. Do I have to be on this statin?
Right. And it's come up a lot more lately with the internet of all things.
Yes.
Statins as a, questionable therapy, cholesterol being good versus cholesterol being bad, yada, yada, yada. Highly contested on the internet.
Yeah. And the evidence. So this is an opportunity for pharmacists to go over the evidence. Like these have shown to reduce your risk of cardiovascular events. You could use some of those like cardiovascular risk calculators to look at their specific cardiovascular risk and frame it in a way that they can understand. And then are they having any side effects? I also, on the flip side, have seen patients having significant side effects like myalgia and muscle pain that are not addressed, and people just brush off by saying you're getting older. But meanwhile, like I also do pharmacogenetic testing. So I've seen patients who have this and who have a genetic influence, which increases their risk of myalgia on statins. And then not necessarily stopping the statin, but switching to a less potent or reducing the dose, and it gets better. So,
right. Especially with that kidney function drop with age too.
Exactly. Yeah. So I think it's just a conversation to have with patients and to frame that risk versus benefit. But yeah, I think there was a lot of like people waiting for this statin guideline, especially because of, just like you said, the conversation, the rhetoric around statins in the public. And so people wanted like discontinue at this age or, with this. And like the guideline doesn't say that, unfortunately.
We love a black or white, but we cannot have it.
Yes. Exactly.
Got it.
All right. A patient has taken pantoprazole 40 milligrams daily for 3 years. They stop it abruptly and develop significant heartburn 1 week later. What is the most likely explanation? Is it A, peptic ulcer recurrence, B, rebound acid hypersecretion, C, pantoprazole withdrawal syndrome, or D, H. pylori infection?
Hypersecretion.
Yes, rebound acid hypersecretion. You got it. So yeah, I think most pharmacists are aware that this is a well-recognized like phenomenon that can occur after stopping long-term PPI use. Basically, our gastric acid pumps are used to being turned off for so long that once we stop the medication, they can kind of work on overdrive and cause hypersecretion. And so a lot of people will stop the medication or wonder if they need it and maybe not talk to a pharmacist or a doctor and be like, oh no, my GERD is back. I do still need it. When in fact, it could just be that, period of hypersecretion, which can be managed. So you can manage that by either doing like a gradual dose reduction, depending on the formulation they're on, like reduce by 50% or do every other day, step down to PRN, switch to an H2 blocker, use antacids.
Yeah. The formulation is a bit challenging with the PPIs, right? It's not like you can reduce the dose as minusculely as you can with some SSRIs, for example.
No, I have seen some patients use one formulation comes in sachets. The lower doses, I don't know how it is in BC or in different parts of Canada, but I know in Ontario, the lower doses are not often covered under certain plans. So that also makes it challenging. But again, maybe if they're motivated to get off, that would be appropriate for a short term. There is some that have sachets. I've seen patients use compounded liquids in this situation too to help slower taper.
And how do you usually run this when you're helping people off medications in Ontario? Like in BC, if I'm working in the dispensary, at least I could do some adapting. but in Ontario, do you send a big fax to a doctor type of thing?
No, pharmacists absolutely can adapt a prescription, adapt the dose. Yeah, adapt the dose down. They can't do therapeutic substitution, so switch to another drug within class, if that made sense. So, for example, say they're on one, but another PPI is covered at a half dose, for example. You would need to get a new prescription for that one. But pharmacists absolutely can adapt a dose here. So they can sometimes deprescribe on their own if they feel comfortable doing that.
Okay.
Next question. You ready? This is a good dovetail from the last one. So this is a true or false. You got a 50% chance either way. Rebound symptoms and withdrawal symptoms are the same thing.
This is a true or false? Rebound symptoms and withdrawal. False. False,
yes. Exactly. Absolutely. I think this was a good one to dovetail off the last one where we talked about rebound hypersecretion. And actually, rebound and withdrawal can happen together at the same time, but they are distinct concepts. So rebound is like return of the original condition, often temporarily worse than at baseline after reducing or stopping a drug. So again, that can happen with the hypersecretion. This has also been studied with benzodiazepines. So like after stopping the anxiety or the insomnia, it comes back even worse than when they originally started it. And then withdrawal symptoms are new symptoms that occur as the body adapts to the absence of a medication after physiologic dependence having developed. So examples in like antidepressants, for example, could be anxiety, dizziness, tremor, those brain zaps we sometimes hear about, especially with SNRIs, nausea, sweating, GI upset, all of those types of things.
Okay. And the physiology of a rebound versus a withdrawal, do we have a clear sense of that difference?
Yes and no. It depends on the drug and the mechanism, obviously. Like, PPIs, we know is like essentially the gastric pumps being turned back on at a higher rate. For drugs that affect multiple body systems, like I think the serotonergic drugs and those types of things, I think they're affecting multiple body systems that, we may not have been aware of when they were on the drug at therapeutic doses. But for example, serotonin, we know is like in the gut, it's all over the body. We're looking at efficacy as treating the depression or the anxiety, and maybe they didn't experience GI symptoms as an example, as a side effect starting the drug, but that doesn't mean that they can't experience them as withdrawal symptoms when coming off.
Right. Or you maybe didn't notice it wasn't a big deal for you previously. Yeah. But then, a little bit of constipation, maybe you don't notice as much as a side effect. But diarrhea, when you remove it, that's gonna make an impact on your day.
Absolutely.
Yeah.
Okay, should we continue with antidepressants?
Yes, I'm intrigued by the antidepressants. Again, like very hot topic right now. We've got the private clinic Outro doing good work in that space. Theoretically, you and I think you are actually performing work on this. I have signed up to volunteer with the Psychotropic Deprescribing Council, and then my life turned into a disaster. So I haven't done as much work on it, but I was all gung-ho to get reading and synthesizing.
No, I think it's a super exciting time for this space too, because I've been doing compounding since like 2015. For a long time, I was, like I said, learning from patients about this issue without real clinical guidelines and evidence, and there's still not great evidence out there. And I think it's not connecting with as much about what we hear from patients and from patient groups out there. But more has been done, and like the Maudsley deprescribing guidelines around this topic have been really influential in my practice, and at least a great reference to share with other health providers to address the why this happens and also the what to do about it and how to safely taper off people who struggle. But I think Yeah. Okay. So let's dive into a question or two around this. So a patient has taken sertraline for 5 years. Their depression has been in remission at least a year or two, and they want to stop treatment. What statement is the most correct? Antidepressants should always be stopped abruptly. A linear taper is appropriate for every patient. Tapering should be individualized based on withdrawal risk and patient response. And withdrawal symptoms indicate relapse.
Yeah, you're not going to stop abruptly. Linear doesn't work for everyone. What were your other options?
Tapering speed should be individualized.
That one. That's the most true.
That's it. You got it.
Yeah.
Yeah. And I think because of your experience and exposure in this, not everyone knows what a linear taper versus a hyperbolic taper is.
Right.
Can you share what you know, or am I only on the...
Yeah. My understanding of a linear taper would be the patient starts at 100 milligrams a day. You're going to go to half dose and keep it there for a certain amount of time, a month, what have you. Then you're going to go down to a quarter dose, then an eighth. And then so you're going linearly down. Whereas hyperbolic taper posits that the response to the reduce in dosage is going to be more pronounced the lower the dose that you're not starting with at the top, but like the dose you currently are on. So you could get away with like going 50% at the beginning, but then as you get closer to like a 10 milligram dose or a 5 milligram dose, those little tiny changes, like going from 5 to 2.5 milligrams, is going to hit harder than going from 100 milligrams to 50 milligrams.
Yes,
Do I have that?
exactly. So hyperbolic tapering, if you look at a curve, hyperbolic tapering is basically that, just like you said, it's basically the serum concentration of the drug. So how much drug we have in our blood is not necessarily correlating to how the drug is working at the receptor or in the brain.
Right.
So what we know is like that first jump or the first few jumps have less impact. And therefore, as you get lower, you need smaller dose reduction. So you can look at it as like a hyperbolic curve. So
an anti-exponential curve.
Yes, just like that. Versus linear would be like dropping 25% every 2 weeks. So 100 to 75 to 50 to 25 and stop.
And you see that clinically with people. You know, you see a lot of sertraline. I have one patient in my mind who I've seen try to stop antidepressants multiple times with an MD. And it's always, we're switching the drug, we're doing a taper, doing well for a week or two. And then as soon as we drop into that lower dose, whoop, right back to the start again. Yeah.
I hear that a lot too. Like the lower doses affect people more in terms of potential. And that's something to look out for too in practice for pharmacists. Like as you get down to the low, if you do see a tapering prescription, it's not necessarily you need to change it right away, but definitely when you're checking, monitoring, calling that patient, especially as they get to the last step or two, because that's where the evidence shows they'll be more likely to struggle and require slower dose reductions at that time. So the first stop or two. And that's what I learned in pharmacy school too. And I know a lot of the, even some of the deprescribing guidelines and algorithms still do recommend that 25% reduction every 2 to 4 weeks. But we know that not all patients are okay with that. I think that there's a spectrum of patients. This is what I see. I mean, I definitely am biased my practice to see the people who need more support. So maybe who are on the other end of the spectrum who don't tolerate that as well. There's definitely people who do tolerate that fine and they're okay. But just to know that that can happen and to be aware and to look out for that in your patients, I think is a good lesson to take away.
Yeah, absolutely. That's a good tip. And just, I mean, if we get anything out of this podcast episode, it's what is deprescribing and, should everyone linearly taper?
Yeah. There you go. No.
Yeah. No. Deprescribing is good. Don't linear taper. Unless you have a unicorn in front of you.
Yes. How are we doing for time? You have a couple more
Good.
questions in
Yeah.
you?
Yeah.
All right. Okay, so this is not multiple choice. I'll just leave it up to you to throw out some answers there. So what factors increase someone's risk of withdrawal symptoms from psychotropic medications or antidepressants?
Amount of time on the medication. I want to say the dose.
Yes.
Like how high the dose is.
Yep.
What factors influence withdrawal symptom potential?
The risk of withdrawal. Yeah.
With risk of withdrawal. The actual medication, like the SNRIs versus the fluoxetines of the world.
Yes. One more pharmacologic factor.
Are we talking all medications or are we talking?
Let's just talk antidepressants.
Antidepressant withdrawal risk. Whether you have some other sort of medication on board that hits the same receptor type?
Yeah, I mean, that could for sure.
Frequency of dosing?
Close.
No, I'm just pulling at straws.
It is PK.
PK.
There's one right at the tip of your tongue. I know. There's medication
therapeutic
type,
window?
Medication type, and half-life.
She knows about drugs. Half-life. Yeah.
Yes.
Okay.
Yes.
That makes
I know you know that one.
Sense. Yeah.
The last one I would watch out for, you hit like almost all of them. Duration of use, how long they've been on the drug, dose, medication type. So notoriously within antidepressants, SNRIs are difficult to stop. Paroxetine as well. MAOIs, although we don't see many patients on these anyways, but those are kind of the ones to watch for that are particularly high risk. Half-life. So for example, fluoxetine is like claim to fame is that it's less likely to cause withdrawal because it has a longer half-life. But I will also say that some people still experience withdrawal on fluoxetine, and sometimes it can come days or even weeks later. So just for pharmacists to watch out for that it doesn't necessarily mean they won't have withdrawal, but like timing also can come into play too. Right.
Might be like famously considered to have less withdrawal, but we just stopped monitoring people in studies too early.
Yeah, exactly.
Yeah. Okay.
And then the last one to watch out for is patient experience. So have they ever stopped this or another antidepressant in the past? How did it go? If they ever miss a dose, do they notice it? How did they feel? Those types of things.
Man, how great would it be if we had a pharmacogenetic test to say you're going to be more likely to have withdrawal symptoms?
Yes. I'm so curious as to like what are the factors that affect people's experience around withdrawal, because I think that there's so much we don't know yet. I think genetic influence is probably there. We just don't know yet. I think that their previous history on psychotropic medications and coming on and off them like abruptly or multiple different types, like that probably influences it.
Or at least is a proxy for the genetic underpinnings or whatever those factors are. It sort of spidey senses you.
Yes. Yeah. So I think there's so much to learn. I feel like 10 years from now we'll know more. I hope so. The research goes into this space.
Well, patients are asking for it, so it seems that we are going to get some good data coming.
Yeah. Okay. I think I got a couple more. Two more?
Two more.
Okay.
I can do that.
All right. So a patient says, I've been taking Zopiclone every night for 5 years, but it doesn't seem to work as well as it used to. What pharmacologic phenomenon best explains this? Is it withdrawal, tolerance, drug accumulation, or reverse tolerance or sensitization?
Tolerance.
Yes.
Yay.
Yes, that was an easy one.
She knows a thing.
I wanted to throw this question in there, especially for Z drugs and benzodiazepines. I think this is important to think of as we factor in that risk-benefit category or risk-benefit assessment for medications, and also a good thing to talk to patients about who may be hesitant to stop these medications when their risk profile is increasing. So as they're getting older, for example, I don't want to stop it. It helps me sleep. But also they're at fall risk, for example, or cognitive decline, those types of things. Like the reality is they don't work as well. And like you can develop tolerance. And I've definitely seen people who are on benzodiazepines for, it can happen as early as 6 to 8 weeks. I've seen patients who are on like, you know, I had a patient who was on Ativan, 1 milligram PRN, and then daily, and then BID for 6 months, and then became completely tolerant to it and was like anxiety crisis through the roof. And like, you can't just keep increasing it. You have to pull back, but you also have to get stable first. So
yeah, it's such a tough one. And we often don't have that conversation when we start a drug that like, listen, getting off of this, we love to say, use a benzodiazepine short term. But short term for a benzo is like 3 days. And it's not a 2-week script.
No.
Yeah.
Yeah.
Well,
and like they work. So like they work immediately. And so people get that immediate, you know, effect on the GABAergic system and calming down. If like, that's why we want to have access to them if you're having a panic attack or a seizure. But when you are using them regularly, that tolerance builds and you don't have anything left to do in those acute situations. All right. Last question. You're a community pharmacist and identify an opportunity to deprescribe pantoprazole, zolpidem, and gabapentin. Name 3 evidence-based resources that could help you create a deprescribing plan.
Oh, I would love to name those for you, but I don't know them. What were there was a benzo,
a Z drug. Oh, sorry, no, Z drug, zolpidem, gabapentin, and a PPI, pantoprazole.
Oh, okay. I feel like the PPI is fairly straightforward. You could just use like RX files or something like that.
Yeah, that's a good one. Actually, RX Files has some good deprescribing guidelines that have come out in recent years as well. They have a deprescribing section, tapering section as well.
Ooh, fabulous.
So good one, check.
That's all I got. Mod sleep. I don't know what that covers, but you said it earlier, so I'm gonna use the test to answer the question.
Yes, absolutely. So Maudsley Deprescribing Guidelines is another great one. It covers antidepressants, benzodiazepines, and Z drugs, as well as gabapentinoids. So gabapentin is in there as well.
Perfect.
Yes.
We'll have to link all those in the show notes.
Yes. I have lots of resources to share with you, but deprescribing.org. So that's or the Canadian Deprescribing Network. So, you know, they're one of the first people to do the research around deprescribing. Canada actually has a claim to fame about deprescribing and a lot of the research initially to bring awareness and to develop a lot of the first guidelines around deprescribing. So there's some really good resources there. There's patient handouts. There's clinician guidelines. There's like little whiteboard videos and educational materials. So definitely highly recommend checking that out. There's also a few others I'll mention, but I'll send you a bunch to link for the show notes. But there's Taper MD, which is another one that has a lot of different types and classes of medications, even some that you wouldn't normally think about, like estrogen, for example, and corticosteroids. They link to other groups around the world that create deprescribing guidelines as well. So that's a good one. And MedStopper is another one, which is cool because MedStopper helps you to prioritize. So if you have like a patient on 20 medications, you can put everything in. You can even put in the indications, and it will help you to evaluate the risk and show you which is most important to address first, at least with the patient. Then you got to consider the patient's goals, values, preferences, and have that discussion. But it can be helpful in that way. But
yeah. Can you imagine if we were trying to do deprescribing and go to the library for all this? The physical library?
No.
Woof. Thank God for the internet.
Or even just like the books on my desk. Thank God for the internet and having 100 tabs open at once, because that's my style.
Yeah. Your Safari is using up all of your bandwidth.
Yes, that would be me.
Well, I feel like I got a really good intro. The concept of deprescribing has been taken from this sort of swirling cloud mass above my head into something that's more actionable, more organized, thanks to you. So where can people find you if they want to connect, if they want your services, if they want you to teach them things?
Yes, absolutely. Definitely on LinkedIn. So Stacey D'Angelo on LinkedIn, D''Angelo. My business is called Your Simple Health, and I'm at simplehealthpharmacist.com. So they're welcome to find me there. Very not active on social media, but I am there at Your Simple Health. But LinkedIn is probably, or my website's probably the best way to find me. So I'd be happy to connect with people. And I hope people take from this that like deprescribing is something that as pharmacists, we are really trained to do. It's like innately there when you actually put attention towards it. And I think patients in the world need us to do this, because a lot of times it just like the medical system is so strapped, people don't have time. And so I think our unique lens and looking for like drug related causes of problems and helping to have these conversations with patients that you know so well, it just like lends to a really good good synergy there. So,
and there is a business case to do it. Don't let your pharmacy owner that you work for tell you not to get people off medications. They will pay for that service.
Absolutely. And it's about relationships, you know, long-standing relationships. A lot of the patients I've had, I've literally worked with for years.
Yeah, which is very valuable, you know. You're not going to lose someone to a bigger discount at a new Shoppers, for example, if you've really actually helped them with their health.
Exactly.
Yeah. Well, thank you so much for being on the show. I'm so excited for people to hear this.
Awesome. Thank you so much for having me.
Thank you for listening to this episode of Rings the Bell podcast. Details for connecting with Stacey are in the show notes, as is the link tree with resources, references, and ways to connect with me. And if you can, as mentioned above, in a very cringe way, I would love a donation to the show via the link in the description. Until next time.